All right. So before I get started, what I want to do is, and I don't always do this, but I am a person in long-term recovery. I have been abstinent from mood-altering chemicals since December 1984. So I've been in the recovery lifestyle for coming up on 40 years here in December. And I don't know if that offers me any additional insights or experience, but this is one of those topics that when it first started coming around about 10, 15 years ago, it really resonated with me. Because oftentimes learning, even in medical schools and where I work at a university in more behavioral health, is we talk about addictions in terms of what it is, the etiology. We talk about the different drugs. There might be things on drug action in the brain, what it does to body systems, but we really focus on the illness. And rarely, up until Recovery Capital came around, was there really work on defining and discussing and really trying to better understand the process of recovery. Now, I'm not going to out the hospital system, but I'm a patient in, my health care is covered through a particular hospital system in Northeast Ohio. And what I can tell you is that I love my doctor. It's David Brill, DO. He's been my family doctor for about 25 years now. I've even told him I want him to be the one that pronounces me dead someday. Because he's a couple years younger, he's in a lot better shape than me, and he checks in on recovery. So even though I've been around for a long time and I've known him for a long time, he will annually ask me how it's going with that. Am I still going to meetings? What's that like for me? And before him, I never had a physician that really asked anything about my recovery or incorporated it into the typical medical visits. Now, at that same healthcare uh, space, we have a patient portal where we could go in and look at our upcoming appointments, those kinds of things. And on my dashboard, it has, my primary diagnoses. So if you looked at my patient portal or my dashboard on my EHR at this healthcare system, it is going to say that, what meds I'm on, no allergies, and it is also going to say alcohol use disorder, sedative use disorder, and opiate use disorder. It does not say remission codes. It does not say I'm abstinent. It does not say I'm in recovery. So my concern is if my physician passes away, or if he gets hit by a bus, God forbid, uh, that the next physician that maybe gets my case, I'm going to be prefaced by a diagnosis that I haven't had any symptoms of in over 40 years. And will I be treated differently? Because even the EHR in that particular healthcare system recognizes the illness of addiction, but it doesn't recognize the recovery. Even though we do have remission codes, at least in the DSM, that that can highlight that. So what we're getting into first is, definitions of when we're talking about recovery, what is it? When I got into this field in the late 80s, recovery was basically the absence of symptoms. It wasn't any value beyond that. It was the absence of symptoms. How long have you been sober? How many sober days in the last year? What is the time of your last drink? In fact, when people were in treatment, and this was in the 80s, and sad to say, some places even now, treatment is an assembly line where if somebody does relapse, and say they're clean and sober for 6 months and they haven't had a mood altering chemical in 6 months, and then they're in treatment and they slip or they relapse or they use over a weekend, oftentimes what happens is they start the treatment over instead of adding on with that experience. They go back to a higher level of care. Do they need that higher level of care? Maybe or maybe not. But oftentimes we look at it like a reboot rather than look at that in the context of that recovery. And do we just approach treatment differently instead of doing the same thing over and over? Are there community factors that may promote or diminish recovery outcomes? And here we're going to get into, in a couple slides, what are some community factors? Are there 12-step meetings in your community? Within those 12-step meetings in your community, is there LGBT meetings? Is there young people's meetings? Oftentimes a meeting might take the dominant culture. Uh, and if I am in the LGBT community, am I going to be welcomed uh, in a 12-step meeting in Southwestern Ohio, uh, in an area where that might not be as accommodating to that population socially as somewhere else? So we have to look at some of these community factors. What are they? What are the clinical implications? Now, there are some definitions that have come about over the last couple of years. There has not been a universal definition for what recovery is that's been used. Now, in SAMHSA, and you can always tell definitions that are built by committees because committee authored definitions are very wordy. I've been on some of these committees. Everybody has to get their favorite word in there because we have to appease all the people in the committee when we're coming up with the definition. But what it says is SAMHSA is a process of change. It's not a result. It's a process of change where people improve their health, wellness, live self-directed lives, and really strive towards their potential. The dimensions that are covered in recovery are health, home, purpose, which is really important, and community. So when we get into purpose and community, we're really getting into some social type of things, some interactions with fellow people. Then we get into William White, and William White he's likely one of the more prolific authors on the recovery concept. He is a consultant with SAMHSA, with NIDA. He's done several books. He even listed a lot of his papers on his website just to make things easy. And he's really one of the forefathers of the recovery management concept. And his definition, recovery is an experience. So we're getting into that process. We're getting into that action of what recovery is through individuals, families, and communities impacted by severe alcohol and other drugs. So when we get into William White's version, it also means that we need to look beyond the self and can a community recover from an addiction issue? Recently I've been involved in a study on trauma and trauma-informed care, and we looked at our systems in Summit County through a trauma-informed care lens, and we realized that not only are individuals traumatized, and we have clinical uh, treatments for that, but communities have been traumatized. And how can we apply those type of healing mechanisms to communities at large? So it also gets in with William White, voluntarily resolve these problems, heal the wounds inflicted by alcohol and other drug-related problems, actively manage their continued vulnerability to such problems, and develop healthy and productive and meaningful lives. And then lastly, we have a consensus panel from Betty Ford. And a lot of these definitions came around the same time in the early 2000s. And we get into recovery is voluntary. So we're seeing that voluntary self-directed type of topic again. Maintained lifestyle characterized by sobriety, personal health, and citizenship. Now, what the consensus panel came up with is 3 stages. And the 3 stages are really due to some of the research by Alexandra Laudet. And she has initiated back in the late 90s and has continued a huge longitudinal study of persons in recovery. She's one of the developers of the collegiate recovery community movement down in Texas Tech. Uh, but she almost all of her academic and research focus has been to better understand persons in recovery, what their trajectory has been since they came into recovery. Real neat, real neat professional too. But she looked at this and found out that lifetime relapse rates don't fall below 15% till after 5 years of recovery. So the consensus panel came up with there is recovery, early recovery, which is up to a year, sustained, which is over one in less than five, and then stable recovery isn't something that really happens until after 5 years. And of course, there's exceptions to all of these. Uh, but given the volume of her study, it seems to be pretty consistent. Now, getting into where recovery movement started, it actually started near the Mayflower Hotel in downtown Akron with Bill Wilson, who is the founder of Alcoholics Anonymous and also the author of the original 12 steps. And what we need to understand about the two founders of Alcoholics Anonymous is that they weren't just everyday people. They were both, by definition, if we looked at it now, would have high symptom acuity with alcohol use disorder. Both of them had withdrawal that was pretty severe. Both of them lost a lot of things. Both of them used every day. Both of them talked about significant tremors when they didn't have alcohol over a period of time. Uh, Dr. Bob Smith or Bob Smith, who was a physician right in downtown Akron, is he began to add sedatives to his alcohol use. And most people know the synergistic effect of adding sedatives to alcohol, which really made his withdrawal that much more severe, and he would have to be hospitalized several times. And these were the two men that founded Alcoholics Anonymous. But one of them was a very successful stock trader from New York City, and the other one was a practicing physician in Akron, Ohio. Both of them, at the time they got sober, were homeowners. Both of them, at the time they got sober, were married. They continued with their marriage into their recoveries after that. Both of them had college degrees. Both of them had networks of, of some pretty influential people. So even though they had high symptom acuity, they have what we call high recovery capital, which means that once they found recovery, they could launch into life pretty quickly. They can hit the ground running pretty quickly. They had a home, they had a family, they had a career. You know, back in that time, Dr. Bob was able to maintain his license. Bill Wilson was able to maintain his contacts professionally. So having high recovery capital does allow people to have a better chance at recovery due to those surrounding circumstances with them. Now, if the first two people that tried to start Alcoholics Anonymous were instead an African American man, we'll just say is Satchel, and a 1930s white homemaker or housewife named Betty, you know, it's a very different situation. Betty is just 14 years into her right to vote. There was no domestic violence protection, you know, at that time. There was stigma surrounding divorce, so people stayed in unhealthy relationships longer. Satchel was in a 1935 America that didn't really think in equal terms of an African American male. So the job opportunities weren't there, the education opportunities weren't there. So neither of these people had the same recovery capital. And if both of them tried to start Alcoholics Anonymous in 1935, chances are it wouldn't have worked. I mean, who would have listened to an African American male that found recovery in 1935 outside of that demographic? Who would have really listened to Betty, a homemaker in 1935, that she found a solution uh, for these kind of troubles? It never would have taken off. Now, the recovery capital term is attributed to William Cloud and Robert Granfield back in the late 90s. And what they define it as is the quantity or quality of internal resources and external resources that somebody could bring forward to initiate and sustain recovery from addiction. There's four types of uh, there's family social, that would include relationships, kinship relationships, social relationships that are supportive to recovery. Are there people that surround me that would really support my recovery? Does my spouse, do my kids, do I have a brother-in-law that's sober? Those kind of things. Does my family have a church life that I could be re-involved in? Willingness of intimate partners to participate in treatment. Being a treatment provider, years ago, I remember how difficult it was sometimes to get family members to participate in treatment because they were done. You know, Sometimes when people get into the late stages of their addiction, they're estranged from their family. By the time they really get into treatment and they're serious about it. The people that aren't estranged from their family and continue to have that support have recovery capital that gives them a better chance. Access to sober social outlets for pleasure and leisure, relation to is there in their area churches and schools and workplaces, where people can go. In community, what is the stigma surrounding addictions in your community? And that community can be the just the geographic community around you, the neighborhood that you live in. Your community can be your demographic community. Uh, but is there a greater stigma in some demographics than others? Is there greater stigma in some communities than others? I know by being a person from Akron, since AA was founded in Akron, that's front page news in the Beacon Journal when it comes around. AA is proud of its Alcoholics Anonymous heritage. I think that may be, I have no reason for this, but I think it may be one of those reasons because recovery is so prominent in Summit County that it is so easy to pass addictions related levies where elsewhere in Ohio, they don't stand a chance. Uh, so those kind of things factor in. Is there a full continuum of resources in your community? I know in Summit County, Ohio, we have a full continuum. We have a standalone detox that serves about $1,500 a year. If you go to Pike County, that I heard somebody, here was working in, I'm not sure Pike County even has a detox. So where can people go for services? All of that factors in. And then cultural. Is there some cultural pathways, into those communities? Is there a cultural pathway for persons of color? Is there a cultural pathway for somebody in the LGBTQ community or in the Native American community? I know where I used to live up in Lorain County is a large Hispanic population. There's a large Hispanic population where English is the second language. And there's actually a Hispanic UMADOP, which is Hispanic Urban Minority Alcohol and Drug Outreach Program. There's an organization, a mental health agency called El Centro on the south side of Lorain. There is services placed in one of the churches in the middle of that community, a Principe de Paz church. Uh, so there's a lot of culturally centric services available. Same thing if we get into Native American populations. But what we're seeing now is there such places for youth? is there such places for the LGBT community? But those are some things that are real helpful, and some communities have them and some communities do not. Now, this is just a simple matrix where it's high recovery capital. Uh, and I'll just give you an example. Let's say someone with high problem severity and high recovery capital. You have a young man, we'll just say 35 years old, alcohol use disorder, uh, high symptom acuity, severe tremors and withdrawal. At the same time, that 35-year-old man is married. He has a house. He has a job in the skilled trades where he makes a really good wage. He has a good health insurance policy, and he's got a brother-in-law that he's really close to that's been in Narcotics Anonymous for the last 15 years and has a lot of friends in that particular circle. So that's somebody that has high problem severity, but they also have high recovery capital. And that might be somebody that, if you just look at the problem severity on the ASAM scales, some people might say, oh, that automatically has to go to residential treatment. But with somebody with that many supports and a high skilled labor job and a career that gives them purpose and a good wage, they might be able to operate with an intensive outpatient service. They might be able to do something outpatient, where if you get somebody else that has low problem severity, they're a weekend warrior. They drink a case of beer every Friday, Saturday, and Sunday. They get in fights, they get in trouble, but during the week, they really don't drink that much. They don't have the money to. They're single. They've been estranged from their birth family. They're couch surfing. They really don't have a skilled trade. They're a high school dropout. They don't have a lot of opportunities before them. So this is somebody that if you look at them just on their illness, their symptom severity is not that severe, but their recovery capital is so low that we might consider putting them in residential treatment with more wraparound services, just because they don't have any supports, internal or external, that they could really bring forward to help initiate this recovery process. So these are just some of the ways where recovery capital really needs to be looked at in terms of our treatment planning, in terms of our level of care, to understand that persons with low recovery capital really do have a tougher time launching into recovery. So these are just some examples of that recovery matrix with high RC or high recovery capital. They have a career, they have insurance, a supportive environment. Low capital, unemployed, unemployable, no trade skills, felony conviction, unstable housing, no transportation, high school dropout, all these kind of things. If we really want this person to launch into recovery, we have to look at them in that context and not just of their illness alone. We already know that with addictions treatment, we have dropout rates from treatment of over 50%. We have really high attrition rates. It has a really high relapse rate, and we're going to get into that in a couple minutes. And this recovery capital concept is something that the more we understand, the better we can treatment plan. The more we understand, the better we can seed people into a level of care that would be most beneficial for them. So when we get into how do we measure it, there are several tools, and I have links on this, and this slide deck is available on Echo. So there's some electronic links to some actual tools. The tools are public domain, so nobody's going to be sending the copyright police over to your house if you download some of the instruments. But these are some of the things that strength items and barrier items. A lot of times with illness, we look at things in terms of what's not there or diminishment. What are some things that are there? And even with exercising regularly, That is a recovery strength item. I know as a mental health practitioner, depression is a sedentary illness. Depression, major depression episodes, somebody just wants to sit, they want to be, they don't want to be active. So something even like walking the dog on a daily basis is therapeutic. For people that exercise regularly, that has it's more than just what's that doing to their body. It's something that they feel good about doing when they do. Uh, Nutrition, health checks. How many treatment programs have nutritional support? How many treatment programs really talk about exercise and have regular exercise? Uh, so these are just some of the barrier items and some of the recovery items. Something as simple as, have you had your driver's license revoked? This strips somebody of a lot of their autonomy, especially if they're from a rural area. My family's from Belmont County, Ohio. It's the biggest city in Belmont County, Ohio is St. Clairsville. My family is from places like Maynard, which you've never heard of just because it's Maynard, or Fairpoint, or my father's side is from Barnesville. Now, when I first got sober, I know that there was a treatment program in Belmont County, but it was in St. Clairsville. And Barnesville is about 18 miles away, and it's the second largest city in that county. And there is no bus that goes from Barnesville to St. Clairsville. Yet in Ohio, if somebody loses their driver's license to an OVI, they're not allowed to drive. So if you're court mandated to treatment, you live in Barnesville, how are you going to get 18 miles away to a treatment program if you're not allowed to drive? If you live in rural America, how are you going to get to work? If you're in the trades and you need a pickup truck that is one of your tools, how do you practice your trade? So we have to look at a lot of these barrier items, sometimes develop treatment plans around them. Now, these are just some of the tools that are out there. So recovery assessment instruments, you could do these in your practice. You could do these with your agency. There's even an agency self-assessment to see if you can have recovery-oriented systems of care practice that you can insert recovery-oriented systems of care type of strategies or resources within your practice. But there's plenty of ways we can measure this. So what we know is that ingredients of recovery capital can predict recovery outcomes. What we know is that social supports, more so than just 12-step meetings, social supports are affiliated with achievement in short-term recovery. Access to and retention in treatment. Do you have access to treatment is a predictor of recovery. Having more people to talk to about important stuff is strongly associated with greater recovery. So even going to a meeting, if somebody is not practicing the steps at the meeting, just having a place to go to where they can talk to other people about heavy, deep, and real things has value. And then if we increased recovery capital first, let's say somebody is in the pre-contemplated stage of change and they're not really willing to look at stopping drinking yet. Sometimes increasing their recovery capital can spark an incentive to trigger recovery initiation. So some of the things that can be done is understand what resources do your patients find the most strength from. So when you look at your practice or you look at your treatment program, have you ever asked your patients or your clients, what is it that you find the most strength from in your recovery? Is it spirituality? Is it meetings? Is it exercise? Is it family? Do you know? And this is one of those questions to ask. What resources do you rely on most for your patients or clients with high problem severity? So are there some resources outside of your practice that you really lean into as a referral for these clients that have severe addiction issues? What support services are most needed by your clients. Ask them, what's missing? Is it recovery coaching? Is it credit repair? In 2018, I was part of a study at the University of Akron where we did a study. It wasn't a large number, but 157 people in recovery. And we asked them, we surveyed them with a number of questions, and one of which, for those that relapsed more than once as they tried to launch into recovery, and many people do, what was the cause of your relapse when you relapsed? And the number one and two reasons were financial distress and romantic issues. Now, we looked at that, and these were 157 people in recovery. So again, not the largest number. I'm not going to say we could generalize this. But we did a quick scan of the existing treatment programs and found out that not a single one of them offered credit repair. Not a single one of them offered, had treatment plans on that. And not a single one of them offered couples therapy on site. So the number one and two causes of relapse per people who have relapsed, our treatment programs did not address. Does your practice provide any kind of recovery capital assessment? And for those that are stable in recovery, do you discuss goals or transition plans with them? Now, this is just something that I think illustrates. Now, I know Chris Ellis Reyes has talked about a concept in the past, and Sybil might be aware of it, called post-acute withdrawal syndrome. And it's just something about after a period of recovery, people bottom out and have symptoms come back again. And what this is, there was a study done in I think it was 2018, 2019, where they did a national survey. And of the survey, they scanned a wide audience. And one of the questions was, did you have a problem with alcohol or drugs and no longer do? And the people that answered positive to that, they got responses from, what was it, 39,000 that responded to that. And once they got down to a weighted sample, it was 2002 individuals. So that's what the survey was. It was a fairly representative sample. Like I said, it was weighted. And what this shows you is that you might not be able to see all these, but the blue line here, and this is years since problems resolved. So we'll say years in recovery. The blue line is quality of life. So in the first 5 years, quality of life goes up. The red line is psychological distress. So in the first 5 years, their psychological stress goes down. The rest of these, happiness, recovery capital, self-esteem, they're all going up in that first 5 years. So in that first 5 years, it's trending up. The only one that's trending down is psychological distress symptoms. But when we focus in on these first 2 years, you'll notice these are very different. So what we're seeing in the first 2 years is what's consistent is recovery capital is climbing. So recovery capital, they are building capital for that first 2 years. But somewhere between 5 months or somewhere between 6 months and 1 year, their happiness, their quality of life, and their self-esteem plummet. And this is something that in early recovery, a lot of people run into finding the reality of their consequences after they have abstained from alcohol and drug use. People get sentenced in court. I've seen people be sober for 2 years before they finally get sentenced in court, and here they are going to prison 2 years after, when they're doing better than they've done in their lives. Sometimes marriages fall apart in that first 6 months or 9 months of recovery. So there's a lot of things that we need to understand. So this begs the question, if we know that a lot of people in recovery really bottom out emotionally from between 6 and 12 months, how come we only keep them in treatment for 28 days? How come we only keep them in treatment for the first 90 days? How come we only keep them in treatment for the first 6 months? when this is the highest relapse potential time, usually right about that 6 to 12 month period. So the first year is a roller coaster. The first year is when they haven't really assimilated into, say, a 12-step community or a faith-based recovery community. They haven't really had friends. All of a sudden, they realize, oh my God, I'm really lonely. Oh my God, I can't do some of these things anymore. I'm not sure what to do. But we need to understand that there's a period, like I said, some people call it post-acute withdrawal syndrome, but this illustrates it well, that people's happiness craters, inside of that first year, and they're not prepared for it. And as clinicians, we need to be. Now, recovery capital and practice, these are just some ideas that were brought forward by William White and William Cloud, who really launched this recovery model. And it's to support screening and brief intervention. Now, screening and brief intervention means we can maybe get people to launch in recovery before they hit bottom. Because we know when they hit bottom, one definition of bottom is they've lost all of their recovery capital. They've lost their home, they've lost their marriage, they've lost their kids' respect, they've lost their trades. For some people, I know with me, I'm a licensed professional. If I lose my license, it would cripple me, financially. It would take away a lot of my purpose. And I've seen a lot of clinicians lose their license over the result of their substance use. And sometimes when people lose everything, they have no incentive to get sober anymore. What's the use? Why try? My family already left me. What's the use? Why try? I've already lost my career. So screening and brief intervention helps get people into recovery before they lose all that recovery capital. With outreach, we know that we have to go out and engage people with low recovery capital. Because, like I said, if somebody's lost it all, sometimes they're less likely to approach treatment or initiate treatment. That's why the VA has homeless outreach programs. That's why organizations like CSS, Community Support Services, has outreach that go into the communities. To assess recovery capital on an ongoing basis, there are some practices that use an ongoing recovery capital scale to help adjust their treatment plans. Because as people get more recovery capital back, maybe their biggest barrier now is getting their driver's license back. Do we incorporate that into some of our treatment goals? Do we use the RC scales to help determine a level of care? Because RC scales help us look at a patient's context instead of just their symptoms. And we need those contexts to really, seed people into the right level of care. Do we target the three spheres in treatment plans, which is personal, family, social, and community? Do we have community development? Does our organization support recovery housing and recovery community organizations? And the way you support that is in Summit County, there's a recovery hub. In Medina County, there's Hope Recovery. In Southern Summit County, Northern Stark County, there's Tyler's Redemption House, which is a recovery center. Do you refer people to those places once they're done in your practice? These are the kind of places that have sober softball leagues, sober bowling. I know recovery, in Medina. They even have goat yoga. They have a 12-step meeting one night of the week that's motorcycle maintenance, that they have a AA meeting followed by people help each other work on their bikes. They just got a farm at the one in Medina. And like I said, they have goats, they have a working farm, and there's a lot of activities. Do you refer clients to these kind of organizations? I'm a person in recovery, and I tell you the truth. I found AA and I found NA, but what kept me sober for the first couple summers was being on a sober softball league. And the camaraderie I had with that, I couldn't find anywhere else. Use changes in their recovery capital as an outcome measure for program evaluations. We've always wondered, how do we measure symptom reduction? This is one of those ways that you can measure treatment success. So I guess in closing, it's really understanding that esteem and quality of life and happiness may crater in the second 6 months of recovery. How might you adjust your practices uh, in response to this? And how do you or might you include recovery capital in your psychosocial assessment or treatment planning? So I'm going to go ahead and get out of this slide deck and open this up for any questions, comments, ridicule,